I want to welcome everybody to the Biomedical Ethics and Humanities Program seminar or symposium on organ transplantation and the biology of brain death, the ethical, economic, and cultural implications. Our speakers today, the reason why I say speakers, even though you see one, is that another one will be joining us shortly, is Rabbi Dr. David Shabtai, and who will be coming is Dr. Teodoro Dagi. Rabbi Shabtai is the rabbi of the Sephardic Minyan at the Boca Raton Synagogue and on the Judaic faculty of the Weinbaum Yeshiva High School. Rabbi Shabtai is also on the faculty of the Strauss Center for Torah and Western Thought at Yeshiva University and coordinates and teaches a seminar for rabbinical students at Yeshiva University's affiliated Rabbi Isaac Elchanan Theological Seminary. He serves as the editor-in-chief of Verapo Yerapeh, the Journal of Torah and Medicine, of the Albert Einstein College of Medicine Synagogue and REITs, and is on the advisory committee of the Albert Einstein College Medicine Program for Jewish Genetic Health. Rabbi Shabtai lectures and writes widely on various issues on the interaction of medicine and Jewish law, and he's the author of Defining the Moment, Understanding Brain Death in Halakhah. I'm going to save the introduction of Dr. Dagi when he comes. The way this is going to work is I'm going to ask a number of questions, which our speakers will answer, hopefully generate some discussion. Then we'll throw out some of the microphones to you guys in order to have the opportunity to ask questions. So first we're going to talk about the definition and the criteria of death, and afterwards we'll talk about organ transplantation. So, Rabbi Shabtai, what is brain death, or whole brain death? And what is cardiopulmonary death?
So legally speaking, in this country, I think all jurisdictions have two different definitions of how a person can qualify as being dead. Either that they have their heart and respiratory system is irreversibly failed, meaning they can no longer breathe and their heart and circulatory system is irreversibly never coming back, or that all functions of their entire brain have ceased. That's according to the Uniform Definition of Death Act, which has been adopted generally in that way across almost all jurisdictions. Brain death, more physiologically speaking, is the end of a process that's generally caused by something from trauma to the brain, where there's a buildup of intracerebral pressure, where blood doesn't effectively flow to different parts of the brain. Different parts of the brain start to stop functioning, and not only the cortical structures on the outside, but even the deeper structures on the inside, eventually getting down to the brainstem itself, the brainstem, the lower part of the brain, which controls respiration.
All right, go through cardiopulmonary.
So in order to, that's all the law says about it, and it must be, the brain death diagnosis must be made in accordance with accepted medical standards, and it's left pretty broad and general and vague, potentially on purpose, because it allows for changes, it allows for advances, it allows for the medical profession to amend it as necessary. Almost always this comes out to having three different criteria: that a person needs to be in an irreversible coma, that they are never going to wake up again, that they have absent brainstem reflexes, not just the peripheral reflexes, but brainstem reflexes, the gag reflex, ocular reflex, and that they have irreversibly lost the ability to breathe on their own, which is controlled also by the brainstem. So the reason that they're focusing on the brainstem so much is not because of a particular emphasis on the brainstem per se, but the brainstem is the lowest part of the brain. It's the brainstem, and the assumption is that that part of the brain is no longer functioning. It means that it's the end process of a larger damage having to the entire brain, that it's so terrible that it's come to even include the brainstem itself, and therefore the assumption is that once these structures are damaged, they will not return. The function will never return, and given that function will never return, it's irreversible, and that is the definition of whole brain death.
Okay, so it seems that brain death is a misnomer, since it conflates the clinical diagnosis with the definition. So just in general, if you don't mind, what is the difference between the definition of brain death, criteria, and the declaration of brain death as a concept?
So in 2008, the President's Council on Bioethics issued a report, a white paper on examining the definition of brain death. And they themselves note this problem of calling it brain death sounds like, oh, the brain died, what about the person? And that's just a linguistic problem, because brain death is is defined as the death of the person. It's not just the death of the brain. It's not like the death of the heart, the death of the liver. It's the death of the person. And so they chose to not use the term brain death. And so although we use it colloquially, they chose to use the term total brain failure. But if you use the term death, so you're already biasing the discussion. Should brain death be death of the person or not? It's the death of a particular organ in that person. Does that qualify as death of the person or not is an interesting question. And so they chose to talk about it as total brain failure. Although they admit that because it's so common to use the term brain death, if you look through the rest of the report, they also slip into use the word brain death every so often. But it is a little bit of a misnomer. So in discussing the determining death, or defining death, or it's important to differentiate between different concepts. The definition, the criteria, and the test. The definition of death is the broader idea, the concept which defines what is the theoretical underpinnings of what makes a person alive versus what makes a person dead. We're talking about philosophy, we're talking about what is meaningful about life as opposed to death, finding those constructs that are meaningful to us. And we may very reasonably disagree about what that may be. The criteria then are those physiological parameters that reflect that definition. If you think that, for example, that the definition of life is the ability to interact with the environment, so then your criteria will be, well, those physiological parameters that allow for interacting with the environment, such as breathing, such as perhaps thinking, such as movement, interacting with the environment. You have a different definition of death. If your definition of life and death is just having continued biological viability, your criteria may be, well, are any of the cells still functioning? Any cells in the body? As long as I have a criteria that the cells are alive, then that would fit. The test then is the practical way of, well, how do I determine whether those criteria have been met or not? The tests are, well, what do you do when you walk into the ICU? What do you do to determine if those criteria are there or not? The tests are the most fluid, although they're also the most agreed upon, meaning most people agree that the test, when we want to test if someone's able to breathe it or not, we can take a PCO2 level, and we're pretty confident that that's an accurate representation of the criteria. So to go from criteria to testing has now been something that's very easily accessible and easily done. Testing, though, is an advancing field. We believe that we have the ability to test whether that criteria has been met or not. There's been recently news challenge to that. Famous case in New Jersey now, J. McMath, who may or may not, it's not so public, that the details of her case are not necessarily public. They're saying that although she met the criteria for death, they're reversible and they're no longer true, and therefore we have to figure out, well, what failed there? Did the criteria fail, did the test fail, or was the whole thing a hoax? We don't really know, but that's generally what that question is raising.
And would you mind just filling this out with regards to cardiopulmonary death? How is that playing in with brain death? What is the...
So physiologically speaking, when a person is brain dead, as long as they can no longer, one of the criteria for brain death is that a person can no longer breathe on their own. So by definition, a person who's brain dead is going to be on a ventilator in the ICU. So they're going to get ventilator support. They're going to be able to breathe through some other means, whether we call it, I guess I'm biasing when I say that we say they can even breathe through other means. Are they really breathing or are they not really breathing? Or are we just providing oxygen to them? They're receiving oxygen through artificial means. And so their heart can continue to function as it normally does. Various other organ systems of the body can continue to function. Pregnant women can continue to gestate their children for the longest time that I saw, according to 107 days, that a baby was able to continue to be viable in the mother who was brain dead. The baby was born a little bit early, but healthy. And so in brain death, the cardiac system is working, or can be working at least. It can be working optimally so long as nothing else happens to that person, nothing else is no comorbid conditions. In cardiopulmonary death, so it's a little bit more fishy because, well, we wait till the person can no longer breathe and their heart has stopped. So how do we know when we can, well, that's easy to diagnose. You can see when they're no longer breathing, you can see when their heart has stopped. It's a little bit more challenging to see, well, is that irreversible or not? Because it's really only the irreversible loss of cardiac and respiratory function which constitutes death. So how do you know if it's irreversible or not? So the easiest way is just to wait. See if it comes back. If it doesn't come back, so then it's certainly now no longer reversible. The question is the more challenging, well, how do you determine in the moment whether it's reversible or not? And that's part of the challenge.
Thank you. I'm going to take a quick pause for a second. So Dr. Dagi is a distinguished scholar and professor at Queen's University School of Medicine, Dentistry and Biomedical Sciences in Belfast, Ireland. He was also senior lecturer for 8 years in the Division of Health Sciences and Technology at MIT, where he contributed extensively to teaching courses and supervising master's theses. He has been teaching at Harvard University's Department of Global Health and Social Medicine since 2011. In the Division of Medical Ethics, Dr. Dagi mentors Harvard medical students in global health, medical ethics and professionalism. He teaches medical ethics and professionalism, and he assists with the development of educational programs in medical ethics.
I apologize for my lateness. The only excuse that I can give is that brain death is not incompatible with apparently a social condition. Try to get through traffic.
Well, continuing, Rabbi Shabtai, you mentioned these two different definitions, criteria, to declare brain death, cardiopulmonary death. Is there a definition of death in Jewish law, or does it just have the same definition as everybody else, or?
So so I'll be a good rabbi and I'll tell you, well, it depends. Most of the questions in Jewish law end up being, well, it depends. Well, it depends certainly who you ask. There's a big debate about it in Jewish law. What constitutes the death of a person? Traditionally for many years this wasn't an issue, not in the scientific community, neither in the religious community. A person was dead when they were dead. There's no question. There's no medical intervention to be had. And so for many, many years this question wasn't really dealt with. Although in the late 1700s this was brought up because there was some concern of people being buried prematurely in Germany. And so there was some debate, there was some actually literature about this in the realm of Jewish law about, well, how do you determine if a person's dead? They passed a law in the different areas of Germany that after a person is presumed to be dead, they cannot bury them for 72 hours, just to make sure that they're actually dead. Because if they're not, then that would be a terrible thing. And in Jewish law, we're very particular about burying someone very quickly. If you ever do a Jewish funeral, it's as soon, we try to do it as soon as possible. Sometimes we wait for children, we make extenuating circumstances, but a Jewish funeral is often, we try to do it as quickly as possible. And so there was some bit of conflict. Do we wait those 72 hours? Do we not wait those 72 hours? How do we fulfill the commandment of burying someone quickly under those circumstances? So in Jewish law, broadly speaking, I always think about it, there are three, in the modern era, meaning relating to brain death, relating to all the modern equipment, modern technologies. I always think about there are three different definitions of what constitutes death, and offered by different people. And so the first is either the irreversible cessation of spontaneous respiration, that when the person can no longer breathe on their own, then the person is considered to be dead. That is one strong, really held opinion, when the person can no longer breathe on their own, which would mean that a brain dead person who can no longer breathe on their own is dead. As with anybody else who can no longer, irreversibly again, and it would have to be spontaneous respiration, breathing on their own. The other approach, and this seems to, at least to me, it seems the majority approach, is that it's the irreversible cessation of what's called vital motion. Vital motion is a broad, more vague concept. It's not necessarily particularly defined from a physiological perspective, but vital motion is something that promotes the continued biological viability of that organism. So even though a person can no longer breathe on their own, if their heart is still spontaneously pumping and their circulation is still spontaneously moving on their own, I say spontaneously meaning if you take a corpse, but it's freshly dead, and you tilt it like this, so you're also providing circulation, you're having the blood flow. That doesn't count as circulation, that's not real. Spontaneous circulation means something that's happening in the body on its own. So the irreversible cessation of vital motion would include, likely, all of those organs that promote vital motion, and the most vital of organs might be considered the heart. So under that definition, the person who's brain dead, whose brain is no longer functioning, can no longer breathe on their own, but whose heart is continuing to function, again spontaneously, would be considered to be alive. There's a third, more moderate position that generally assumes that it's the irreversible cessation of vital motion, but has a caveat that, and maybe we'll get to how Jewish law works, and it's based on case studies, that if a person's head or brain is completely considered to be absent, then they would be dead. They would be considered to be dead as well. So the question is, well, how does that parallel to brain death or not? In brain death, the person's head and brain are still there, although they're not functioning completely, not completely, depending on the case. So the question then would be, according to that definition, would that be an alternative way of getting at the definition of brain death?
Thank you. Rabbi Shabtai and Dr. Dagi, this is a question for the two of you, because it seems that there are multiple definitions of death, some of which are more dominant than others at different times, yet Judaism is a very legal religion and seems to get its definitions from, like you said, case studies and legal analysis, where other societies, the American Society for one, let's say, looks at its definitions more from a philosophical perspective. or from a perspective of social theory, let's say, as well. How does one create these definitions based on underlying philosophical premises and underlying legal premises? How does that process work in order to come with such concrete definitions, such as the ones that you come up with or mentioned? Either one. We'll go back and forth.
So let me start with a little bit of historical view. Can everybody hear me? Back. Okay, great. Let me start with a little bit of a historical view. The 17th century, what Rabbi Shabtai mentioned, which was the 17th century, 18th century movement in Germany to be sure that somebody was dead and delayed burying them, is actually very, very old. You can actually trace it back to viruses, where people are concerned about premature interment. And when you look at it, there are two parts. One was you delay because you want to make sure that somebody is actually dead, and the other is in case they revived when the technology was available, you actually did things like put telephones inside of coffins so that if they were to wake up, they could call out. And there are places like a cemetery on Q Street in Washington, Mount Auburn Cemetery in Boston, where wealthy people would subscribe to a telephone service for a week to make sure that they could actually call out. But that's sort of an epic phenomenon. The real phenomenon may be different. There are two issues when you talk about a non-religious system when it comes to death. The first is one which is philosophical. What does it mean to be alive or dead? Is life and death something which can be defined in terms of an organ? So there's a very famous surgeon by the name of Bichat in Napoleonic France, who paid the government a number of pennies with sous to be able to study people as they were being mutilated. And he studied the heads and he studied the bodies. And he came to the conclusion that the head was not necessary, the brain was not necessary for life, because of this idea of vital movement. He was able to show that whether you were talking about chicken or you were talking about a human being, it's very gruesome, there was movement after death. There was no movement, he said, if you remove the heart. Therefore, the head and the brain were not necessary for life. That was one of the French views for a long time, and it had to do with this thing that we would now call the intersection of physiology on the one hand and philosophy on the other. The philosophy of what was life, vital, strength, vital movement, and the physiology, which was how to breathe. But there was a legal problem, which was much, much deeper than that. And the legal problem has to do with the legal definition of death, which is pretty much universal, even though it may take different forms. At death, unless someone is a royal, like a pharaoh, or a king, or a hero, one loses rights. One cannot own property when one is dead. One cannot bestow property when one is dead. One cannot have wealth. From a religious perspective, there's certain things which people owe the dead, but the dead doesn't owe to others. There's an asymmetry, and that asymmetry did not exist before death. So if you take as an example, King Edward II of England, a very early medieval king, after the Norman Conquest of 1066, sent around coroner's examiners. Coroner, the crown. Examiner, people who had the office of the crown, in order to see whether people who claimed to be dead really were. Why? Because in this tax structure of medieval England, all debts returned to the crown after somebody died. And so the wealth of the king was in part defined by, and his ability to make war and to have property was in part defined by a clear definition of who was dead and when that person died. You then have taxes, inheritance taxes, where if you agree that somebody should be able to inherit a piece of property, taxes come back to the crown. And there are all other kinds of people. Does everybody know the word disparage? You know where that comes from? To disparage somebody is to take the widow of a nobleman and to threaten that widow with disparagement or being demoted to the level of common if she did not agree to be married according to the dictates of the king in order to do something which was politically advantageous to the crown, either from a financial standpoint, from a land standpoint, from a treaty standpoint. So those are two different sides of death that have nothing to do with what we're talking about right now, which has to do with when you find out that somebody's really dead. But they matter a lot in terms of what is going on. There's also another word that I'd like to introduce here, and that word embraces or bridges the different ideas of God. And the word is to deem, D-E-E-M. To deem something is a legal term, very old English, and it means to consider something whether or not it is. If I deem this to be a ballpoint pen, and you all look at it and say it's a fountain pen, well, if I deem it a ballpoint pen, I'm treating it as if it were a fountain pen, as if it were a ballpoint pen, whether or not it is. If I deem you to be a physician as a medical student, I'm giving you the rights and privileges of a physician, whether or not you're graduated. And that might happen in time of disaster. If you deem somebody to be dead, then you treat that person as dead, whether or not you actually have evidence that they are. And what's an example in civil law? If somebody disappears for 7 years under American law, they are deemed to be dead. We don't know that they are. We may not have a corpse, but we deem them to be dead, which means no rights of property, inheritance goes on, the will is probated, and so on and so forth. So the real question is, one, what is the definition of death? Two, when do we deem somebody as dead, whether or not they meet the criteria? And three, what are the differences amongst different systems that may have different ideas about deeming? And the ideas that Rabbi Shabtai just brought up were three ideas around deeming somebody dead, which is different than declaring dead. There was a terrible crash in Washington in 1982. It was known as the 14th Street crash. A plane went into the river, and there were people who were rescued very, very quickly. It was particularly catastrophic because an EMT who was freshly minted was given the duty of deciding who was alive and who was dead. And frankly, he had no idea what he was doing. There were physicians there, and the physicians were prevented by the police from taking care of patients who might have been alive and might possibly have been resuscitated, but were not, because those individuals were declared dead by the EMT. Well, how could that be? After all, declaring dead is a medical function, right? It's not. It's a police function. Because the police are the extension of the government and therefore the crown. And even though it was a catastrophe, it was a travesty, by law, that was correct. And so the declaration of death is a legal function. The finding of death, according to certain criteria, can be medical, or it can be philosophical, or it can be religious.
Thank you. I know, Rabbi Shabtai, I want to ask you about the Jewish legal boundaries, but I just want to push this question, which will go back to yours as well. You mentioned, talking about state interest, police functions. In certain states in America, we have two legally valid criteria. How does having a law that has that type of ambiguity affect not only individuals who would be under the law in those different states, but the idea of having a uniform social ethic or a universal standard that's based on an American ethos? And then, of course, I'll ask the same question to Rabbi Shabtai with regards to different definitions of life or death afterward.
In effect, you have a may declare and you have a must declare. You cannot take somebody in any state who has no cardiac function, no respiratory function, and say, oh look, that person is alive. What you can do is artificially support circulation and artificially support ventilation and say, I will continue to treat that person as if he or she were alive for some purpose, delaying until a family can come by, delaying until certain religious rituals can be imparted, delay until organ transplantation can take place. You can't say that person is dead for now. You can't say that person isn't dead forever. What you do is you delay. When you come to brain-based criteria, you're talking about something else. If you go back, and I would recommend that everybody do that at some point in your careers, to look at the 1967 Massachusetts General Hospital consensus statement on brain death. There's several different parts to it. Number one, the assumption. The assumption was that somebody had suffered irreversible brain dysfunction, and it was whole brain. The second was in the original but not final statement, that the brain had liquefied. And you all know that if the brain stem is no longer functional, you will not maintain blood pressure, and you will not maintain respiration or ventilation. So the assumption was, on that level, cardiorespiratory and cerebral or brain-based criteria were identical. Not later, it evolved, but that's the way it started. The third was that there was a need to make this distinction that people who were on a ventilator would still be deemed dead by brain-based criteria for two purposes. One was to get them off a ventilator. The second was to be able to triage and to be able to use the beds for people who were, in fact, use the words if you want, deemed to be alive, survivable. And then there was a third parenthetical criteria, which was, we're doing this because we want to have organ transplantation. Up until that last parenthetical piece, nobody argued. It was when you got to that last piece that you had to argue. Because then you have conflict of interest. And the conflict of interest may be financial, because there's money associated with transplanting. It may be because you want somebody to die before you, so you can save somebody else. Well, that's really philosophical. That's a huge problem. Are you allowed to take one person's life, and I'm going to use the word, in advance of their actual death? Sloppily saying, knowing that we have to find it, in order to save somebody else. Can you take out a heart like a Mayan priest would to give it to somebody else, if that would rescue somebody else, or can you not? It then turned out that the criteria diverged. The cardiorespiratory criteria did not change. On the brain-based side, people began to say, well, there may actually be two things we're talking about. One is a brain not functioning and non-recoverable, and no other system that we know of to be able to maintain respiration, ventilation, oxygenation, circulation. The other was something along the lines of, well, this individual is no longer a person who will live in the way in which that individual would want to live. And, logical and, meaning both have to be there, that person has suffered brain death. And that's where the discrepancy came in. That's where Dr. Bedzow's idea really got to two different points. When you began to think of either partially brain dead, if that's what you want to talk about, if that's what you want to call it, or a philosophical view of a life not worth living, in in someone who has brain damage and extend that to me, that individual will, and here's that word again, that individual will be deemed to be brain dead. Then you really are deemed to be brain dead. One, the possibility of cardiorespiratory function, which we agree with, and the other, we disagree with the desirability of that kind of life. Let me stop there.
And we will continue on that train of thought, but I just to get back to, I guess, even, if you will, I would love to know, we've seen the philosophical side in the secular ethos with regards to the Jewish legal tradition establishing more than one definition as well. Does it play out in a similar way, or are the tensions different? Please.
So from a Jewish legal perspective, again, there are two different perspectives on it. There are those who accept brain death as death and those who don't. So they're sort of irreconcilable, because one assumes that each side assumes that there's only actually one definition of death. It just happens to be that they disagree. However, there is that third approach, which actually entertains two different possibilities for death, as I mentioned. Either the irreversible cessation of vital motion, in most cases where a person just dies naturally. That means regular plain vanilla death. That's one author put it. And will also entertain the complete absence of the brain or the skull or the head or something like that. So how can you possibly have two definitions under that circumstance? There are two different criteria. And so from a Jewish legal perspective, I don't think it's problematic. Because if we think about it, and as I think what Dr. Dagi was mentioning before, the definition of death is not a fact. It's more of, it reflects a philosophical system. It reflects when are we assuming that a person is dead. It's an idea that we can disagree about. It's not a fact that we're looking for. And so from a Jewish legal perspective, it's a particular status that this person has. They are now dead. Now, it could be that a person could arrive at that status from two different perspectives. It's not that the criteria per se are what's important. It's that those criteria reflect some definition. So it could be, and I don't see any theoretical reason that it couldn't be so, that a person could arrive at that same definition from two different perspectives. For a bad analogy, in Jewish law, we're particularly concerned, when is a baby considered to be born? For whatever reason it is, when is a baby considered to be born? And the standard assumption is when its head emerges. And when it's a breech baby? So that also its head emerges? No. So then we have another system when the majority of the body emerges. Okay, so how do you have two definitions of when the person is considered to be born? Because it's not that criteria per se, which is what we're looking for. We're looking for something else that reflects something important, and it's either the head or the majority of the body, but they both reflect something else. So from a Jewish legal perspective, I don't see any problem with having necessarily two possible definitions, or two possible different sets of criteria that are both getting at the same thing. Because it's this definition, and from a Jewish legal perspective, we sort of can hide behind the definition of, well, it's a departure of the soul. What does that mean? But if it is, then there's no reason per se that it has to fit one particular physiological parameter as opposed to another physiological parameter. Either one might get you at the same idea. So I don't necessarily think there's a problem from a Jewish legal perspective.
No, I hear you, but I want to push you just for a second. If you look at a question in the case, you may read the majority decision, you may read the concurring opinion, dissenting opinion. They're all looking at the same case. But they're coming up with different responses or different understandings of what's going on based on their analogical reasoning or based on the values that they're weighing in different ways. How does that happen with regards to, or what are the values that are in tension in Jewish law that is creating this one opinion and dissenting opinion?
So leaving aside that third opinion that allows for different opinions, we're talking about the two conflicting approaches. So getting back to how Jewish law is determined, it's really case-based. We believe that there's an oral tradition, the written tradition. The oral tradition was more case-based, and as it got written down, we have particular cases, and we have rules that come out of those cases. And again, these are a little bit ancient, and so we have to figure out, well, how are we going to apply those cases to modern situations? And so often the cases are not parallel, we have to derive different rules from them. And so, just like every other aspect of Jewish law, we're stuck with the same situation. It's the same methodology that's involved in figuring out any other question. Well, given what we know about death, or cases of death in Jewish law, and again, remembering that this was not a particularly difficult thing to do back in the day. It was pretty obvious when a person was dead, and we didn't have any medical intervention, so there isn't a tremendously large amount of material to draw from. So now we're a little bit stuck. It does give us a lot of leeway to try to say, well, we have 3 different cases, well, how are we going to put them all together? We have to understand how they fit together. We can be a little bit broad because we're only limited with a certain number of cases, so we can create an interesting structure to try to put everything together. But on the other hand, we only have 3 cases. And when we're talking about, is a person alive or dead, so if they're alive and I treat them as dead, then I may end up killing them. And so because the stakes are so high, there's been a tendency to be a little bit more conservative in this area, because the stakes are so high. Now, when we're talking about organ transplantation, the stakes are high in both directions. The stakes are high because we have a donor who may potentially be alive, depending on how we can figure it out, and we have a recipient who is alive, but may not be for much longer. And so being conservative on the criteria is not a very simple thing to do. It's not very simple at all, because it's not that I'm just always choosing life, because I'm choosing life, but on the other hand, I'm not choosing the other person. So that the systems that are developed from those cases are going to reflect on certain values. And so the irreversible cessation of vital motion is based on the assumption of reading through a bunch of different cases in the Talmud, in the rabbinic literature. That's the principle that is felt that can put all of these cases together. That's what's driving this case law, and therefore now applied to modern day, that's what happens. Or the other approach is irreversible cessation of spontaneous respiration. That's what's driving those cases. And therefore, if that's true, then we apply that to the model. And so that's how I'm not sure if I answered the question.
No, I understand. I'm going to follow up also. Would you like to say?
Yeah. Maybe this would help a little bit conceptually. Everybody knows what blindness is, right? Have you ever seen the term legally blind? Okay, so somebody who sees can still be legally blind. And we're talking about something like that when we're talking about 2 systems. Clearly, somebody who's born anophthalmic without eyes doesn't see in the way that any of us think about seeing. Clearly, somebody who has bilateral enucleation doesn't see because both eyes are gone. Clearly, somebody who has optic nerve damage doesn't see. But you have other people who are also called legally blind, even though they might perceive light. And ultimately, there's a value issue, and you ask for what purpose? Is it an absolute or is it relative? And what matters here is, somebody is declared dead, and you say, forgive me, I don't mean to be rude, so what, who cares? Well, if it's dead because of economic consequences, and then you remove care, you might be hastening their death if they're not really dead. And you may care about that a whole lot in some religious systems. And if you don't care about it, you may take a very different approach to it. So if I may, I think what Rabbi Shabtai is saying is, look, if you care about, if the stakes are such that making a statement and a determination that somebody is dead on whatever criteria, the color of their forehead, I don't care what the criteria, means that there's certain things that don't happen, then it depends on what the stakes are. It depends on what happens. If that means that you may be killing somebody and you don't want to kill somebody, that's a very big deal. If it doesn't happen, then it may not. I can tell you that I was accused of murder. I was chief resident on the Chelsea docks.
That was the reason.
That was the reason. On the Chelsea docks in Boston, which was a very, very rough area where the Navy still had docks. There was a gang that laid in wait for a sailor, beat him up, and smashed his head in. There was really nothing left. Came to the Mass General, tried to save him, and could not. There was a point at which we resuscitated him time and again, the 3rd time, and the 4th time, and the 5th time. This was futility. There was nothing left to be done. And the brainstem was, by any criteria, gone. And I was satisfied that by any, at that point, definition of brain-based criteria for death, or if he had not been supported on a ventilator, cardiovascular or cardiorespiratory criteria, this individual was dead. So I wrote a note and said, this individual meets both brain-based criteria and cardiovascular criteria. And on that basis, I will disconnect the ventilator. The defense in the murder trial wanted to make me an accessory to the murder because I had pulled the plug. And what saved me that entire story was the fact that he was declared dead before the ventilator was discovered, and not after. And the conceptual change was you could declare somebody dead while they were still supported on a ventilator. And that was very important.
So, Rabbi Shabtai, Dr. Dagi mentioned a number of motivations, say, or reasons for adding another criteria, adding brain death as a possible definition. What was the motivation for rabbinic scholars to add another definition for death, considering it's a very long tradition of had?
So I don't want to guess on people's motivations, so I'm going to speculate only, and it's my speculation only, but I do think it was organ transplantation. From a Jewish perspective, from a Jewish legal perspective, saving a life is of the utmost importance. We have a lot of rules, and we are willing to violate pretty much almost every single one of them in order to save a life. A person who keeps the Sabbath can violate the Sabbath, eat not kosher, can do whatever is necessary to save a life. So we're pretty adamant to want to save lives. So organ transplantation is one way to save a life. Then we are need to consider that very, very, very seriously. Is this going to be something that's permissible or not? Because if it is, then not only can we do it, but we should be doing it because it's going to save lives. Now, so I said we can violate pretty much anything in order to save a life. One of the three exceptions is murder. You can't kill one person to save another. So in the case of organ transplantation, well, you need to determine is that donor alive or not. If the donor is dead, and so then there's no question at all. You can do it. You're not murdering anybody, and therefore you're not ending that person's life if they're alive. By taking out their heart, you're going to end their life, presumably. Therefore, you couldn't do it if he's alive, but you could if he's dead. And so I'm again speculating again, but if you look at the literature as it came out, that's pretty much what they wanted to do. They thought that organ transplantation, that is a way of saving lives. It's something we need to take very, very, very seriously. And the only thing that would stand in our way is pretty much murder at that point. Meaning, and I use murder in the very, very, very non-legal sense. I'm not a legal scholar. Not in the legal sense, what do we mean? Are you ending the donor's life? Very broadly speaking. If that donor is still alive, removing their heart and their life. And so that's pretty much where it came from, I believe. That it was mainly based out of the motivation to try to save as many lives as possible.
What do we think? Another theme, another trope in this. Prior to 1640, anybody who appeared to be dead was dead. The exception was people who were hanged for a crime. If people felt that they did not deserve to be hanged, then as soon as the sheriff disappeared, they were cut down, put on a rude cart, and brought across terrible roads on an unsprung platform, and often they started breathing again by the time they got to the surgeon, and everybody thought that was a pretty good idea. By about 1640, starting in Holland, it was clear that people who fell into canals could somehow be resuscitated, and if enough water was removed from their lungs, they might start breathing again. So there became extant something of an obligation to resuscitate. It wasn't a medical, it was a bystander resuscitation. And there were royal resuscitation societies in England and throughout Europe. The American Coast Guard was really part of the resuscitation society, especially fishing villages, but any place where there was a body of water. By about 1880, it was pretty clear that everybody felt that there was no religious objection to resuscitation, although there had been religious objections to resuscitation. Because if you believed in a religious system in which your purpose on earth was to get to heaven, and you had no purpose being on earth other than living through that corridor, then there was no advantage to trying to be resuscitated. In fact, dying was not a bad thing. By 1880, it was pretty clear in almost all of the religious literature that was extant that there was no objection to resuscitating. In 1965, JAMA published an incredibly exciting paper about external cardiac massage being able to resuscitate people. And the headline was unbelievably emotional. It said, anyone, anywhere, can now resuscitate. And so everybody was taught resuscitation. In Washington State, you had to learn how to swim and to do cardiopulmonary resuscitation in order to graduate from high school. Same thing in many other states. Something happened between 1965 and 1970, which was a recognition that not everybody who was resuscitated actually was alive. Resuscitation as a test of death was the first idea. Resuscitation to forestall death was the middle idea. Resuscitation to guarantee life was the third idea, and the third idea failed. And then the question was, okay, what do we do next? And that's when the idea of looking at brain death, because of failed resuscitation, really came to the fore. And the transplantation, which started about 1964, was really the motivating factor that made that possible. So I think from an historical standpoint, the way in which you just constructed that is very, very plausible. And the critical time frame is 1964 to 1961.
Before we begin to talk about organ transplants, a practical question. You have a family who lives in New York, has to go to a hospital. New York has the legal exception for cardiopulmonary death. What happens to a family, whether religious or philosophically inclined, has a moral objection to brain death, is put into this situation? How does that work in terms of the hospital, the family, their rabbinic leaders? What happens? What occurs? We've been talking a lot in theory. Give us a little bit of, paint a picture for us in terms of the practical experience.
So I'm going to make an extreme statement, and I think I can stand by it. I cannot remember any case ever in my career as a neurosurgeon where I was actually asked to declare somebody brain dead or dead by brain-based criteria, or whether there was a controversy about somebody's status that turned out to be an irresolvable compromise. There was always a way of dealing with it. But it was a negotiation. It was not always a statement, and it didn't happen at the time, necessarily the moment at which people wanted it to happen. So why do you care about what happens after a declaration of death? There are two things: resources that we spoke about, and then there's organ transplantation. In religious law, there's something else, in Jewish religious law, which has to do with what you're allowed to do in terms of actually approaching and moving a corpse, and who's allowed to do it and what happens. But let's leave that out for right now. Let's just call that a religious ritual. Let's leave that out. What most families want to know is that, one, there is really nothing more that can be done. Number two, and it sounds so absurd to say this as I say it, but I don't know of any better way of saying it. The patient is really dead. Doesn't appear to be dead. There's not going to be a story where they wake up tomorrow. Nobody will ever regret it. The third thing is that the religious ritual wants to be respected. Nobody wants to say, okay, we're taking off the ventilator because we've decided that this patient is dead, and it doesn't matter what you think. So in general, the approach that needs to be taken is a discussion with the family about what the real physiology is, a really full discussion. Number two, the involvement of whatever religious authorities, religious legal authorities, are necessary. And I'll leave to Rabbi Shabtai the stories in which there's some controversy. I'm sure that that occurs. How you get around it. Number three, an understanding that timing may be very, very important. So something may not happen in the middle of the night, it might happen the next day or 2 days. Sometimes you need to do that. And then the last thing that's very important is to realize that people really may have different views of what constitutes death. And if a family wants to maintain its religious views above and beyond the physiological, then the best way to deal with it is to involve a rabbinical authority or a religious authority, somebody who's not necessarily Jewish, who will be able to discuss and act as an interlocutor.
I'll just echo one thing. One of the most important things that I found both as a rabbi and a doctor of practice is that you have to have a conversation. You have to actually have a real conversation, which means that if it's a religious-based objection to whatever's happening in the hospital, whether it's the determination of death, whether it's a procedure that needs to happen, whether it's a certain, whatever it is, and the family is coming and saying, well, we believe X. Now, they might be very well educated and may actually understand what's going on, and that's fine. In many, many cases and in many, many families, it's not one person making that argument. It's a whole bunch of people coming together, and they're not all on the same page necessarily, and they're all reflecting opinions of someone else. So in Jewish circles, for example, someone may call the rabbi and say, is this procedure okay? And the person may say no and hang up the phone. And that's really a travesty, because they really have to have it. So sometimes it's obvious, sometimes it might be an obvious question, but usually, more often than not, I don't know if there is any case that's so obvious. That it's not, and there actually has to have a real conversation. And so, I try to do that a lot, to try to just put people together in the room, or at least have a conversation on the phone. Let's actually figure out what's going on. Let's make sure we're all on the same page. In so many of these circumstances, whether the condition of death or not, people are just, first of all, we're not working on the same facts. And I understand that families and, both from professional experience, personal experience, families are not always ready emotionally to hear all the facts, and sometimes some members of the family are, some members aren't. They're not all actually listening, even when they're in the same conversation. Not everyone's on board with just what is happening, what's the plan. Even once we have a plan, just need to get everybody on board to have that conversation. It's so important. Often that alone, I think, resolves so many conflicts, just to get everybody on board, get everybody on the same page. This is actually what's happening. People will assign motivations. They'll say, you just want to take, I've heard this more than once, you just take my grandmother on a ventilator with us, either you hate old, short women, or because you're trying to save money and there are 6 empty beds, why do you need to empty this bed? There are 6 empty beds in the ICU, you don't need this bed to be empty. So people are assuming motivations on the parts of other people, and that just needs to be. Now, it could be that they say, our ICU is full, we believe the Jew's dead, and I got 6 people waiting to come in. And that might be a way to think about it, but it just needs to be expressed and spoken about and expressed as values. And people can have different perspectives. People can come from different values and value systems, and when you can actually have a conversation, more often than not, you can acknowledge, well, this is it's not that I'm right and you're wrong. It's not that I have to be right and everybody other than me is wrong. It's, well, I have this value system and therefore I believe X. Oh, and you have a different value system and therefore you believe Y. And we might be at a standstill in terms of practically what to do. But once we've given that background, it's a lot easier to move forward when I can understand and respect another value system and not think that the other person is just a fool, or the other person, more often than not, the medical establishment, I would say more often than not, in many cases that I've seen, people will assume that many physicians will assume that if a family doesn't agree with them, they're just not educated enough in that medicine, they're not just educated enough in biology. Sometimes that's true. It's true a lot. But sometimes it's just different value systems you got to bring people together. Practically speaking, there are some times where from a Jewish law perspective, again, since there are different opinions on it, so different people come from a different perspective. If they're of the opinion, they're from a group that assumes that a brain dead person is alive, so then a family will not consent to organ donation because they believe that the person is alive. They may also not consent, may or not, it's a different question. Given that the person's alive, assuming so, well, how do you treat end-of-life patients? This person's literally at the end of life. They're not. Opinion 1 is end-of-life patient. There's no hope for recovery. Everyone agrees that. We're assuming the facts are correct. There is no hope for recovery. There's just a dying patient. They're just not dead yet. Well, how do we treat such a dying patient? And so, again, you're going to have a full spectrum of different opinions across the Jewish legal spectrum. And some may allow removal of ventilators. Some may insist that a ventilator not be removed. Some may require that no action be taken, but nothing changed. Meaning, from the Jewish law perspective, we're often more interested in what you do and my obligations towards another person in terms of my actions, as opposed to the outcome. So while the obligation may be to take care of this person, I may have to, often such patients are on vasopressors because their blood pressure is falling, and so they're on vasopressors right now and their blood pressure. And from a Jewish law perspective, I'm taking care of that patient. So, and they're on a ventilator. And from a Jewish law perspective, many will assume that, well, I can't shut off that ventilator because I'm taking action to shut off that ventilator, that might be a problem. But on the other hand, when the bag of vasopressors empties, well, do I have to hang another one? Because if I don't, I didn't actually do anything. I was passive. And from a Jewish law perspective, there's a very big difference between active and passive. And often, that's a way to resolve some of these issues at least, because practically speaking, most of these patients need intensive care, but they need active, involved care all the time. And if someone's going to be passive in that case, and assuming that that's the perspective they're taking, that will be one way of resolving the issue. And I think in most cases that I've been involved in, at least, presumably Dr. Dagi will agree, more often than not, and more often not 51%, by a serious percentage, that's how the cases are resolved, even when there's irreconcilable differences. And again, a lot of it's just based on having a real conversation.
There's a negotiation that goes on whenever you speak to patients. And all the physicians, everybody who's been on the clinic will know this. It's a multi-party negotiation. It's between more than one physician, typically, more than one specialty, typically, more than one type of care or practitioner. There will be nurses involved. There will be other people involved. A physical therapist may say something which may really change the way a family thinks, either towards you or against you. You will have religious leaders. You will have many family members. And so there are a couple of things. One is not everybody is equally suited to this negotiation. There are physicians who have empathy, and there are physicians who don't have empathy. This is a case in which you need empathy. The second thing is, you can generally go very, very far in this kind of negotiation if you keep in mind some very basic questions to discuss with the family. And one of them is, what do you believe? Or what do you don't believe? What do you want? What do you think? What do you care about? What do you fear? What are people afraid of? And addressing these, unpacking and addressing each of these questions is often very, very helpful. Because what you need to tell the family is that what matters to them is significant to you. If you eliminate that as a fear, that they don't count, they're irrelevant, they don't matter, then the conversation becomes much, much easier. Another thing from a practical standpoint that I found very helpful, and I think a lot of people now do, is to bring patients, bring the family into the patient, and go through the signs, go through what you're seeing, educate. The more you educate them, and their representatives from a religious standpoint, often the easier it is to have that conversation. It really is a real conversation. And you have to be prepared for families turning to you and saying, you're an idiot. You don't know anything. You don't care. You're a murderer. You're an assassin. You have to be prepared for that. And you have to have enough emotional maturity to realize that they're not attacking you personally, but they are attacking the situation which you happen to represent with the speaker. But you're not actually who was being attacked. And the next thing to do is to say, if something gets very heated, is to say, well, why don't we continue for an hour, and let's get back together in an hour. Give it a little bit of time. Because it's amazing what happens over time. Sometimes it's more than an hour. Sometimes it's very hard. And I guess the last thing I would say is, don't expect that this is going to be easy on you. Because it often isn't. Because if you do have empathy, you will feel for the family as well. And these are very, very hard decisions often. But they're harder emotionally than they are physiologically. Very, very often.
Both of you have spoken greatly about the importance of organ transplants and the value of organ transplants. Do you think, or should America have a presumed consent for organ donation, as they're starting to have in countries in Europe and elsewhere? How do you feel about the idea of presumed consent?
Since from a Jewish law perspective, we're assuming again that most organs are going to be taken from patients who are pregnant, and therefore legally speaking, considering that from a Jewish law perspective, there's somewhat of disagreement whether that person is alive or dead. I don't think it would be wise from a personal religious perspective to have such a law, because then the person would have no say as that's not correct. A person would have say, but they would have to opt out. And so the assumption is, well, who thinks about these things? I mean, in some other random end-of-life cases that I've been involved in, you have cases where people just don't like to talk about it. I have this obsession with end-of-life, morbidity. I talk about it at the table. My wife thinks it's strange, but like I talk about it, it doesn't bother me. My wife knows exactly what I want done. She knows exactly where I want to be buried. She knows all of these things because I'm comfortable talking about it. I'm weird. I know that. Other people don't like talking about these end-of-life situations, and so they don't exactly know, well, what's going to happen if they can't make decisions. They have 5 children. They're all grown. They have grandchildren. Who's going to make a decision for that person? They have 5 children, all different perspectives, grow in different places. Who's going to make decisions for what needs to be done? Not something simple. Not like, well, if X, then I want Y. Well, who's going to make the decisions for power of attorney? People don't like thinking about end-of-life issues. So the question is, maybe we should encourage that. I think we should educate people to encourage that. So the hesitation is, well, even if we assume that there's an opt-out system, meaning there's presumed consent, where you could opt out if you so choose. I think we're going to be in the same situation where a person doesn't want to talk about it, doesn't want to think about it. I mean, how many people even sign the back of right now where we have an opt-in system? And so the back of a driver's license, in New York State at least, you can sign the back of a driver's license that you consent to have your organs taken. I don't know how much legal weight that carries, but it doesn't make a difference. So I think, how many people actually sign that? How many people sign yes or no? How many people write no, don't take anything, or take everything? I don't know that those numbers are so high. And so, given that there's some controversy in Jewish law about it, whether it's right or wrong, and people are so hesitant to deal with these issues, that yes, everyone could opt out. That's true. Everyone could opt out. That's true. I'm a little bit nervous about this, about how it would pan out. And
well, let me ask you this, because it seems you made 2 points. One was the Jewish law, and the other was it's like a political psychology. Right? In a country like Israel, where the rabbinate has ruled that brain death is considered a halachic death, so Jewish law might not be an issue. Then you're just dealing now with psychology. But does a state interest put pressure over individual psychology in this respect, considering that there's no longer a Jewish law issue, seemingly?
Assuming that were reflecting the situation in Israel, which I don't think is true. The Israeli rabbinate doesn't necessarily reflect the opinion of all the Jews living there, because there's room for opinions, etc., etc. But if that were just leaving that question aside, would there be a problem with it? I mean, from a Jewish law perspective, there's somewhat of a disagreement. Let's say for those who assume that a person is dead, or let's say we could, today we're limited from the medical perspective, and only somewhat so, of taking organs from brain dead patients. What if you had someone who was dead according to cardiopulmonary criteria where there's no disagreement about it? And we find some way, and I think we can have kidneys, control the donation of cardiac death, or control the donation of cardiac death, where a person at least theoretically could experience, whether it is or it isn't, somewhat of irrelevant for right now. A person that cardiopulmonary criteria, which everyone would agree to, is accurate, would you still need consent to take those organs? And so from a Jewish law perspective, the question comes down from, once a person's dead, as Dagi said, they lose their rights. So what rights does a dead person have? So none. So, why not take those organs? Is it considered stealing? Is it not considered stealing? And even if it is, you're taking something without permission. Who do you get permission from? Well, who would I ask permission from? Who do they belong to? So from a Jewish law perspective, it's a little bit murky, but I don't know that necessarily there would be an issue with it. And some have written, in fact, that it would be something that we should consider very strongly. Again, leaving aside the definition of death issue, assuming that a person is dead for whatever system you're in, that we believe that organ donation is an important thing. Do you want to get into that, or wait?
No, actually, I want to hear what Dr. Dagi says about the U.S., and then I actually want to open it up to some questions, because I've been asking all of them, and I feel like it's not that fair. I'm the one asking questions.
So I'm going to go to a very basic philosophical view, which is you have consequentialist views and you have duty-based views, logical and consequentialist. If you ask from a consequentialist standpoint, should you do it, if you define your right as some type of outcomes-based criteria, then the answer would be yes. Because probably, if you argue greatest good for greatest number, probably making more organs available and probably making them more easily available would probably save lives and would reduce the number of people on the roads. If you believe on a duty-based, if you think along duty-based lines, then you end up saying, well, do people have a right to determine what's going to happen to their body? And do they have a right to determine what's going to happen to their body afterwards? In law, every right has a corresponding duty. So if you believe people have a right to determine what's going to happen to themselves and their bodies, then the next question is, do you, as a medical establishment, have an obligation, on the whole, to respect those rights and to say some people may simply not want to? And then the question is, if you have an opt-out program instead of an opt-in program, and if that opt-out program is really very, very well implemented, are you worse off on a social level by doing it? I have to tell you, I don't know the answer. I can argue it both ways. There's very, very little that we have as a comparison for an opt-out system short of conscientious objection in wartime to the draft. When we said that the draft in America covered everybody, that people have a right to opt out if they're conscientious objectors. So there's some kind of precedent. And then it depends on whether you're looking only at the collective or whether you're looking at the individual. We tend in the US, as opposed to Europe, to think in the sense of the individual and not to think in the sense of the collective without some kind of qualification. That's just the tradition. We don't do the Robin Hood thing of saying take from the rich and give to the poor. We say each has property rights. So I really have to reflect what Rabbi Shabtai said, which is really this is a problem of property rights. If we say people do not have property rights on their own body, does that mean we can grab somebody as soon as they're declared dead and bring them into a dissecting room and simply dissect them, right? Because they have no property rights. They can't say no. Can we say that we can experiment on cadavers? We want to do physiological experiments. Can we do that? Or is there something else that we're talking about, the dignity of the human being, respects for persons, that says, no, we can't do that? And if we argue the collective, we might say, well, you can do that for purposes of organ transplantation, but you can't do it for dissection. You cannot do it for physiological experiments. I can see both arguments. I would tend to come down on the side of guarding the rights of individuals to preserve their ability to dictate what can be done with their body. That's not the rule in France or in the West.
No, thank you. Thank you. Does anyone have any questions? If you do, there's microphones on both sides of the seats.
Hi, I'm Dr. Golombek. The concepts that you discuss are interesting, although I wish life would be as easy as you put it out. It's not really black and white. Even less when you put the Jewish law in the middle of it. And most of the concepts, with all due respect, that you presented were very simplistic. And they're definitely not applicable to babies. There's no brain death definition for babies, at least not in the state of New York, where we practice. So it's really not that black and white. Nothing of what you said could be argued with a rabbi whether a baby is dead or alive on a vent, on high doses of dopamine, dopamine, epinephrine, when there's really no way of defining brain death. So it's really not as simple as you would like sometimes.
Absolutely, 100%. I apologize completely. We were talking about, I was talking about adults, although I didn't say that caveat, it's supposed to be extra F. And you're
that's why I wanted to clarify, because a lot of students, and life is not that easy when you treat babies, like it seems to be with adults.
The physiology is much, much more complicated, I believe. I'm not familiar with the physiology of babies. Infants, neonates, etc. The physiology is much, much more complex. And yes, much more complex, and therefore not only is the physiology more complex, so therefore the determination, philosophy, and ideas behind it are, I believe, are similarly much more complex. And absolutely correct. We should have started with subject matter.
My question is to you, Rabbi Shabtai. There is a reasonable literature on brain death and Jewish sources, and in your book you have a masterful review of it. It's not a huge literature in terms of one compares it to other concepts, but it certainly is there. And the question I'm going to end up with, I think you probably will answer by saying, well, we have all these sources, we have to run with it, and we're limited by that. But I'd like to suggest there could be another alternative, one which poskim rabbinic authorities are reluctant to use, but one which at least avoids the dilemma in which we really find ourselves. Because the implication of the complexity which you document so well in your book is that we have a variety of decisors. We're far from consensus on it. And the bottom line is that traditional Jews who observe Jewish law are continuously in conflict with many, many hospitals, producing a whole host of issues. That the implication is that Jews will really not donate organs, because once we accept the dead donor rule, halakhically we have to have a Jew to be deceased in order to extract the organs, with the exception of kidneys and live donors, which is another whole area, which is a voluntary situation and is discussed in rabbinic authorities. Essentially, if we must define the individual as deceased, then essentially it means that traditional Jews will not contribute organs. So we have this horrible situation where a traditional Jew will accept an organ but will not donate. So we have a whole host of moral dilemmas that come out of our sources, which I think, if we want to be honest, and I'm reflecting on this as I struggle dealing with patient cases such as these with great regularity here in our hospital. There is another whole approach which is not the traditional one, I recognize, but it goes back to the sources, and you say this in your book probably at least a half dozen times. When we look at the texts from which we derive our principles, it is exceedingly difficult to convert them into contemporary medical concepts. And therefore the question basically is, unlike other areas in Jewish practice, we have the right to define our own reality. I'm not going to prolong the question, but just to make an analysis, if Judaism prohibits cooking on the Sabbath, Judaism defines what constitutes bishul, what constitutes cooking. It's our own internal system, it's a ritual issue. A Jewish child might not say that constitutes cooking. But we have a right to write our own system. When it comes to scientific phenomena, however, there is another reality. And one could argue that when you take the Chatam Sofer and his description of how the body functions, and his reality does not understand circulation of all the issues which this audience is well familiar with, or you look at a Rashi in his commentary. Rashi died in 1105, and is the major commentary in the Talmud, and it describes something having to do with the death process. And all the commentaries, as you document so beautifully in your book, struggle with trying to convert Rashi into modern terminologies. There is another approach, indeed not the traditional one, which would simply say, let Judaism get out of the death business other than the ritual areas and leave the science to the physicians. So that the whole definition of death that we try to develop from our sources is laden with complexities and difficulties. And I think it's the same thing as looking at the creation of the world and trying to see, well, how does it sit with evolution? And one could take a whole host of issues which the Bible and our sources refer to. Unless we see them as mythopoetic and look at them as philosophical concepts, once we start to say, well, they're giving us realia, they're giving us scientific information, Judaism can indeed come up with a position on the creation of the world, the universe. It lends us in a whole variety of areas. So my point is to say, given the onus that the sources that you and I live by have created vis-a-vis definition of death and implication of organ donation, etc., there is another way of kind of approaching this. I acknowledge not the traditional one, which basically says, given that we don't know how to read these sources and to convert them effectively and convincingly into modern categories, we might just follow the science on this, come in with the religious elements, the ritual elements, but really get out of the death business.
Shabtai, would you like to respond?
Sure. So first of all, it's a very important question. It touches on a lot of methodological issues in Jewish law, which I'm going to explicitly say we're not going to deal with right now. Probably bore the daylights out of most people in the room, so I'm going to ignore that for the moment. I will note again that, as Rabbi Shir mentioned, that the traditional approach is to look to those sources and to try to be convinced from those sources applying them to modern day, and that's been the traditional approach in everything. Now, the point is, in terms of doing so here, I think everyone has to agree, even if I'm thoroughly convinced that I'm reading a medieval commentary from Dagi in 1105, I'm thoroughly convinced that what he's saying applies today. Although I'm thoroughly convinced, I have to recognize that he didn't have all the information that I have today. That's clear as day. I'm aware of that when that happens, and so when I say I'm thoroughly convinced, I keep that in mind. And I'm not saying that I particularly take any approach, but in any issue. But I think one of the underlying issues I think needs to be addressed, and I might be starting the issue, but I'm not intending to do so on purpose, is that, well, is the determination of death that we've been discussing a scientific phenomenon or not? We sort of skirted it, and we mentioned that definition is a philosophical idea. It's the criteria of the physiological parameters that reflect that definition. The tests are those medical abilities to determine whether those criteria have been met. But ultimately, what defines death, I think, and I think most biophysicists might agree or disagree, is a philosophical notion of what it means to be dead. It's not a medical fact. Medicine and science are limited in what they can do. They're limited in terms of math. They're limited in terms of yes and no. They're limited in terms of relationships between different things, mathematical relationships. They're not able to answer a question of why. So whatever criteria I give, I can always go, well, why should that be? And whatever the doctor might respond, I go, well, why is that important? Why should breathing be important? Why should breathing? And you have to give it a philosophical basis for that approach. And so fundamentally, the definition of death is either an ethical, philosophical, or, for my personal life, a religious definition. And so it's not that there's a fact to be had. And so if it were true that there was a fact, and that I think the situation would be different. If there were facts on the ground that this set of criteria is what death means, what it is, then I think the religious perspective might have to reflect differently. But I don't see it that way. I don't see it as death being a fact to be had. It reflects a particular value system. The legal profession, in my opinion, the way it works is it reflects it's supposed to at least. Whether it does or not might be a different conference. It's supposed to reflect the values of the people of the United States, of our county, of our state. It's supposed to, in theory. And so it reflects those values. It's important that those are reflected in law. But that's still a value system. And so from a Jewish legal perspective, I say, well, there's a different value system. And so it's not acquiescing to a fact, which might be one set of criteria. It's whether we're going to say, well, we have no value system here, and we're going to just take a value system from somewhere else, which I think is still might be something to be considered, but I think it's a different type of a question that needs to be asked.
We have time for...
Just
let Dr. Dagi take a comment, and then we have time for one more question, and then maybe after we can, we'd love to hear a response.
Just very briefly, I think the principle that comes out of that is that there are two different discussions. One is on death, and the other is on participation in organ donation. And here, as Rabbi Shabtai said earlier, I think the feeling right now is that organ donation is very important and is something which, from a social and halachic perspective, is permitted under the right circumstances. And so I would emphasize that the influence on the Jewish community and the policy of the Jewish community should be to educate people on participating in organ donation programs when organ donation is permissible. And I think that's what's going to make a big difference. Those movements are out there.
Question?
I've been working in transplant since 1974, first as a technologist, and now I direct the transplant out of it, Westchester Medical Center. And I think that the process is much, much more complicated than we can, talk about tonight. But I'd like to say it's only been in recent years that legislatures have actually passed laws in order to respect the wishes of the person who signed their donor card. There have been many instances where someone wants to be a donor, but when it comes down to harvesting the organs, when there was the objection of significant others or family members, those organs were not used. And now we have legislation that respects the rights of the person who signed the card. And I think it's a very, very, difficult decision to sign your donor card and to be a donor. I've been in the field for over 40 years, and it took me 20 to sign my own donor card. And I'll tell you just one little anecdotal story. About 20 years ago, when my daughter was around 10 years old, we went to a memorial service at the Organ Donor Network in Virginia. And we spent the day, and she saw donor families talking about the benefit of donation and how that helped them. And they were recipients of organs who talked about the benefit of receiving the gift. On the way home, driving down the expressway, my daughter turned to me and she said, Daddy, if something happens to me, I want to be an organ donor. And I turned to her and I said, well, that's really terrific, Sharon. I hope we never have to make that decision. When we traveled a little further, she said, Daddy, I really want to be an organ donor, but I'd like to be a little older like Grandma.
Do you guys have any response to that?
Thank you.
Because that is a great way to
That's great.
close. Listen, everyone, I want to thank everyone for coming. I want to thank everyone for recognizing that this could only be at most an introduction, and that there's so much more that we need to discuss, which means we should have Dr. Dagi and Rabbi Shabtai back so they can continue to discuss them. Thank you guys so much for coming.